Good afternoon, everyone. Welcome to our webinar tonight on group therapy for borderline personality disorder. This is part of the McLean Hospital webinar series on borderline personality disorder, which we hope is really a resource for families and also patients and others who are interested in helping people with borderline personality disorder. Before we get started, just a few logistical announcements. First of all, my name is Chris Palmer. I am a psychiatrist here at McLean Hospital and an assistant professor of psychiatry at Harvard Medical School. And it's really my pleasure to welcome all of you to tonight's webinar. We are delighted to have with us George Smith, who is a licensed clinical social worker. He's on staff here at McLean Hospital, and he's the program director of the Gunderson Outpatient program, which specializes in the treatment of borderline personality disorder. But he's also the director of the outpatient group services for the entire hospital, so group treatments across a broad range of disorders. And he's also a teaching associate in psychiatry at Harvard Medical School. And he'll be speaking with us in a little bit on group therapy for borderline personality disorder. All of you who are logged in via your computer, I want to let you know that your microphones have already been muted. But we really do hope for and expect participation from all of you tonight. So if you look at your screen, you should see 5 different boxes. In the upper right-hand corner, you're probably seeing my image. The main portion of your section should be a big slide. In the lower right-hand corner is a question and answer box, Q&A, and we encourage you to type in your questions there. If you have questions about your loved one or questions about the content of tonight's webinar, or even just generic questions that aren't entirely related to tonight's webinar but are related to borderline personality disorder or helping someone that you care about or love who has this disorder, feel free to type in those questions and we'll get through as many of them as we can. If you've come to tonight's webinar with a specific question in mind, feel free to go ahead and type it in right now and we'll put it in queue and again try to get to as many of them as we can. One quick announcement: we are looking to improve our webinar series and learn from our experiences. We've been doing them for almost a full year now. And so we're looking for feedback from you. And on that main screen, the lower portion of that screen, there's a link to a SurveyMonkey questionnaire. And we're looking for feedback from you. So if you wouldn't mind participating in that survey, that would really be great. And that link is also provided in the lower left-hand box. So the lower left-hand corner of your screen has a lot of web links, and the very last one is a link to that survey. Additionally, we have another webinar coming up on August 10th. Dr. Karen Adler is going to be speaking with us on strategies for improving communication and decreasing conflict. And so if you want to register for that webinar, you can do so again in the links in that lower left-hand corner. Finally, one question that almost always comes up in all of these webinars is, where can I find help close to where you live? And we are McLean Hospital, located in Belmont, Massachusetts. And so we can certainly help with referrals in this area. But we have participants from literally all over the world, not only all over the United States, but really several other countries. And so we can't possibly know who the treaters are in all of your areas. And so the 2 resources, or 3 resources that we most highly recommend are those first 3 links in that the web links page: the National Education Alliance for Borderline Personality Disorder and the BPD Resource Center. Those are 2 great resources. Also behavioral tech. If you're looking for a clinician who's trained in DBT, they have a list of treaters who are trained in DBT. And So with that, I am going to go ahead and turn our webinar over to George Smith. So take it away, George.
Well, thanks, Chris, and it's a pleasure to be here. Although I'm a strong proponent of the value of psychotherapy groups in general, I believe that groups are especially effective for patients with borderline personality disorder. Borderline personality disorder, or BPD, is characterized by problems with emotion regulation, and interpersonal hypersensitivity. Groups provide an ideal forum to address these problems. They help identify the commonality of experience. Patients can tune into each other with an understanding of what it's like to suffer from these conditions in a way that are exceptional and often go beyond what the rest of us can do, and that includes clinicians. They're all in the same boat, more or less, and by conveying that understanding, patients and the groups can feel heard and understood. They can also challenge each other about maladaptive behaviors with a unique credibility. They can call each other out because they've been there too. Patients with borderline personality disorder are sensitive to perceived rejection, and they have an underlying fear of abandonment and often have difficulty tolerating aloneness. They crave intense connections usually, although when they get those connections, they can just as easily feel suffocated, or it can be rife with conflict. This often gets played out with the people closest in their lives, their families, their romantic partners, and even their therapists. Borderline patients usually prefer having individual sessions over groups, but the individual sessions can lead to problems with overdependency or can be a setup for conflict. They may experience their therapist as not noticing their pain or not responding to the way in which they need them to. Groups can help diffuse this intensity. Our program recommends a balance between individual sessions and groups in pretty much equal numbers. Let's go back to the basic problems associated with BPD: emotion regulation and interpersonal hypersensitivity. I'm going to describe specific groups that we've developed in our program to address these problems. The first is something called self-assessment. It puts a premium on being aware of one's emotional state, more or less in the here and now. The patient is encouraged to take a personal inventory. What's coming up for them right now? What's on their mind? What are they feeling? What happened in their life yesterday? What's coming up this afternoon? There's an interplay between identifying their internal emotional experience and external experiences from their environment. The second of our main areas involves skills groups. DBT is the best known of these, and it emphasizes emotion regulation, distress tolerance, mindfulness, and interpersonal effectiveness. There's also an emphasis on chain analysis, in which if an individual gets upset about something, they're encouraged to try to work backwards and identify links in the chain which led to their getting dysregulated. Skills groups, and DBT in particular, are especially effective with problems with impulsivity. And if the person is really feeling unhinged in the evening, DBT skills can help them get through the night. The third of our main area emphasizes relationships. And I'm going to divide the relationship focus into two main camps: mentalization and interpersonal groups. Mentalization is a cumbersome sounding word which describes something that I think you'll recognize because it's built into our wiring, which is a capacity to read another person. We all get an idea of what's going on in another person's mind based on facial expression, body language, tone of voice, things like that. The problem is we're not as good at it as we think we are, and we all have a tendency to read into a situation and make assumptions about what's going on in the other person's mind. My experience with borderline patients is that they have particularly long antennae. They're very perceptive, and they can perceive the slightest shift in a person's mood or tone. The problem is they make assumptions about it and are highly reactive to it and can really be off to the races in a hurry. Mentalizing helps them to slow that down and to recognize that they were picking up on something that probably was there, but to accept the idea that they actually don't know what it was, and to, instead of making assumptions about the other person, try to take a more inquisitive stance and be curious about what was going on in the other person's mind. Mentalizing also encourages them to apply that same way of thinking to themselves, because often the way we interpret somebody else says more about what was going on in our own minds than was actually going on with the other person. Mentalization is especially useful with the reactivity associated with borderline patients. The second of our relationship-oriented groups are interpersonal groups, which are traditional process-oriented psychotherapy groups. They encourage patients to examine relationships in their lives as well as relationships in the group. At its best, an interpersonal group can serve as a real-time laboratory to examine how people experience each other. And it's an opportunity to get skillful in being real and authentic with each other and to give each other feedback about how one another is experienced. At its worst, an interpersonal group can turn into a free-for-all, and it's especially important for leaders to be active in helping the situation or the discussion to not escalate and put a particular emphasis on helping people to remain skillful or civilized in their interactions. Those are the mainstays of our group program, and I would be interested in thoughts or questions about what I've described.
So thank you, George. This is Chris Palmer again, for those of you who may have just logged in. So we are opening the floor for questions. And one question particularly related to what you've just presented on is somebody asks, you've talked about the value of group therapy, but how do you quantify and evaluate the benefits of group therapy? So if somebody's participating in group therapy, how do you think about measuring or evaluating whether it's really a good fit for that person?
Well, that's a good question, because they're not for everyone. We have had participants in our program who have gotten overstimulated by what happens in groups, and they seem activated in a way that is dysregulating. So even though our standard model is to encourage people to be in groups, sometimes we have to be selective about which type groups, and it may be that something that's more skills-based and has less of an interactive emphasis within the group works better for them. And other people seem to benefit more from having individual sessions, even though our experience is that it's better to encourage more of a balance between individual work and participation in groups. The relationship focus groups can be the most challenging, especially the interpersonal groups. And one of the characteristics of BPD is they're often avoidant about conflict, and because the conflict can be right in front of them in an interpersonal group, it may be that that makes people feel very uncomfortable. And part of what we do as clinicians is try to assess how much to challenge the person to not avoid or avoid avoiding, as the DBT clinicians say, or at what point do we accept that it really seems too activating for the person and they're better off with other forms of treatment.
So, George, one question I want to pin you down on is, can you describe maybe an example of a situation where a group could be harmful for a patient? So one example that comes to mind is sometimes people are concerned about the concept of contagion. So they might have a child with borderline personality disorder who has never cut herself. She starts going to some groups and she hears other people talking about cutting themselves, and lo and behold, she starts cutting too. What do you think of the concept of contagion, and are there other situations in which you think maybe a group therapy might be harmful in some way?
That's a really good question, and it's a controversial issue. The conventional wisdom over the years has been to avoid discussing graphic details about something like cutting. So we'll generally encourage patients to refer to behavior like that as self-harm or target behavior. And by going with the euphemism in that way, it is more protective and guards against that contagion effect. I've had other patients more recently say that they feel limited, by having those guidelines, and that they would find it helpful if they could talk about how out of control they get with behavior like that. I still discourage graphic details, and and if they go through how they went about getting something they're going to use to harm themselves, that seems unnecessary and off what we're talking about. But by being able to talk about a sense of losing control, and by identifying what it was, what they were doing when they lost control, sometimes that can provide a kind of holding and containment, which is valuable to patients. I would never open it up in that way with a group that hadn't already established a solid cohesion. And if in these recent examples, when a group member has identified that they thought it would be helpful for them to be able to talk about it more openly, I'll check it out with other group members and to see where people are with it. And it's a careful titrating of the process, but it would be a mistake for clinicians to say, we want to talk about everything and everything, because that doesn't serve anyone's interests.
Great, no, that's really helpful. So the next question might be a little complicated for some who don't understand mentalization. So this participant says, I understand the theory behind mentalization, but can you please expand upon what mentalization treatment looks like in a group? And are there specific skills taught? Are there modules? How do you go about teaching a more inquisitive, curious stance?
Well, that's another good question. I took a 2-day seminar in 2004 when mentalization was first gaining recognition around here. And while I found it theoretically interesting, I had trouble wrapping my mind around it in a way that I could use in my clinical work. And then in 2005, I learned about a model that they were using at the Menninger Foundation, in which they offered structured exercises in which people could practice mentalizing. So the way we handle it in most of our mentalization groups now is everyone gets oriented to the basic concept, so that which is much along the lines of what I said earlier in identifying how we all have a tendency to read into each other and make assumptions. And but really keep it fairly simple. When I first started doing the groups, I gave everyone articles that described it in more detail. But what they described was that they found the readings too dense and confusing. So giving them a simple explanation of what we were trying to accomplish worked better. And then what will happen in our mentalization group is that usually two group members in each group will volunteer to mentalize a situation that's happened recently in their lives, where another person said something to them which was really upsetting, or said something to them where they didn't know where the other person was coming from. It was really confusing. So as a group, we start off by identifying the facts without making any interpretations about what it meant. And once we've clarified the facts, we speculate as a group what might have been going on in the mind of the other person when that happened. And we try to come up with as broad a range as possible with hypotheses with as wide a spectrum as we can. Often, all of us will be landing on one side of how we imagine what was going on the other person's mind, either coming up with a harsh or critical view of them, or a kind and benevolent view of what might have been going on. And if we notice ourselves being lopsided on one end of the spectrum or the other, in the spirit of mentalizing, we'll try to come up with hypotheses that will balance it out and give us a broader range. So that's about the other person. And we speculate as a group about what might have been going on in their mind. And then as a group, we speculate about what might have been going on in the mind of the person who's actually taking a turn. And we go back to the event that they described and speculate about what might have been going on in your mind when that happened. And as we go through both sides, the other person, of what I call the mentalizing equation, the other person and yourself, usually we come up with perspectives that hadn't occurred to the individual. And after we've gone through the two sides, we'll ask them, what was this discussion like for you? And usually there's been a shift in perspective. And they said, gee, I hadn't thought about it that way. Or if that's what had been going on, that would have changed everything. Anthony Bateman, one of the developers of mentalization, sat in on one of my groups a few years ago, and he said, at this point, you also want to ask the rest of the group what this discussion was like for them. Because what typically happens is the issue we were discussing may be close to home, and another person may relate to it. So giving them an opportunity to talk about what it brought up for them. Mentalizing puts a high premium on transparency. So the group leaders are encouraged to be transparent about what's going on in our minds too. And so we'll participate in the mentalizing process of coming up with hypotheses. And if I'm aware that the group discussion brought up an issue for me, I'll share that. It would not be something, having to do with, my personal life. But if it had something to do with, what came to mind about some frustration or sadness, I'll share that. And then at the end of the discussion, we'll ask the individual, well, what thoughts do you have about the next time you see that person? And usually they have a shift in emphasis and may have questions that they want to ask the other person, saying something like, I wasn't sure what you meant when you did that. Or I didn't know how to take it, or I found it really upsetting. And it leads to constructive discussions with the people in their lives. I should have mentioned at the beginning of each mentalization group, we ask the members for any updates. And often they'll report back to us about what happened when they went back to the original person. And more often than not, something constructive happened. And for me, when I started doing mentalization groups, the concept came to life and it made much more sense to me. And I'm impressed that the patients in our program get it pretty quickly. And one of the indications that we're having success in helping people to mentalize is in other groups or therapy situations, sometimes the person will be talking about an interaction that they had with somebody that was upsetting to them. And it'll be like a light bulb goes off and they'll say, ah, this sounds like something I need to mentalize. And I think when they have that recognition, they're 80% of the way there. Mentalizing is a fun group. The spirit of it is to be playful and to kind of move things around. And it helps move us out of our rigidity and away from some of the assumptions that can be long-standing.
Great. That's a really wonderful description of a mentalization group and gives us kind of a snapshot of what you might be doing. So I think that's really helpful. Another participant asks, are there groups for people suffering from borderline personality disorder that also have a history of trauma? And are there groups that can help them overcome their personal trauma?
Our borderline program puts less of an emphasis on that. And like your question earlier about discussions of self-harm, we need to be delicate about how we discuss trauma because it can be triggering to someone else who may have had traumatic experiences in their lives. So within our groups, having the person acknowledge that something traumatic had happened in their past, and if there's something currently which is bringing that up, that is definitely some of the work that we would do in our groups. I've been at McLean forever, and 20, 25 years ago, the emphasis regarding trauma was that you did not want to encourage the patient to get into the actual content of what their traumatic experience had been. In other programs in the hospital where there's more of an emphasis on trauma, there's new research that suggests that helping people to explore the trauma in more of an exposure can be effective, provided it's done in a highly skillful way and with a therapist with whom the person has a secure attachment. That is not something that we've done in our program, and we handle issues regarding trauma in the way I described before. But I want to recognize that we now have some trauma groups in the outpatient clinic, and the thinking about what can benefit patients, so that rather than being stuck with these traumatic experiences that follow them around, it now seems that by being able to actually delve into what happened to them can take away the emotional charge that it has, so that while it's still there and it's still upsetting, it doesn't haunt them in the way that it did before.
No, that's really helpful as well. So a couple of really great related questions. So I'll start with one. You spoke about sensitivity to perceived rejection is one of the not uncommon traits of borderline personality disorder. So how do you think about this trait in the context of the group process? And how, when you're running a group, or for people who are participating in a group, I imagine that comes up, not uncommonly. And how do you think about it in terms of the group process, and how do you handle that in the context of a group?
Well, it does happen, and people can say things that are hurtful to someone else, either unintentionally or sometimes intentionally, because people get upset with each other and have resentments that sometimes seep out in their groups. So when someone identifies that they feel rejected or feel hurt in some way, you generally want to start by validating it, and usually the other members of the group can see how something would have been upsetting. So you want to start with validation. However, part of the value of a group is that you're going to have a range of perceptions of what happened. Provided you start with validation, somebody else can say, I see what you mean, although I experienced that comment in a different way. And similar to what I was describing about mentalizing, if you kind of move it around and look at things from different angles, that too can take away the charge. So you don't want to leave the person high and dry and say you shouldn't feel that way. I mean, that's totally invalidating to respond to them that way. So you want to start by recognizing that I can see how that was upsetting, or, you know, I'm sorry it came out that way, and I can see how that was hurtful. And then try to move it around in ways that, you know, might look at it, you know, from different angles, and to help people express what they were saying in ways that might have more of an edge, and might be something that's more palatable to the person who was initially wounded.
Great. The next question is, I think a really great question, and maybe it might be a little bit difficult to answer, but so considering the interpersonal difficulties and the fear of abandonment that can be commonly seen in borderline personality disorder, is it possible that if a patient is doing really well in a group and really feels connected to the group members and really feels like this is an important part of my social network and support, that that fear of abandonment could almost hinder the changing process because she or he might be afraid of getting too much better and therefore having to leave the group or no longer really needing the group or being as sick as the other people in the group. And how do you think about that? Do you ever see that? And if so, how do you think about that?
Well, it reminds me of something else that's known about the treatment of BPD, which is, at least the theory goes, you're never supposed to tell a borderline patient that they're getting better. And the thinking behind that is that might lead to this fear that people are going to think that they're doing better than they really are. One of the problems that can be associated with BPD is something called apparent competence, where the person looks good on the outside. You know, they're functioning well, their relationships seem better, and everyone judges that you know, because the problems that brought them to treatment have improved, that they're actually doing a lot better within themselves than they actually are. So it can be challenging to you know, not go overboard with you know, praising their success, and yeah, personally, I think it goes too far to suggest that you can't tell them that they're making progress, but that was the original thinking. You raised an interesting concern, though. It can be very gratifying to you know, be in a group or lots of groups with peers, and within our Gunderson outpatient program, I believe that part of the therapeutic action is you know, what the participants get from each other outside of you know, specific groups or therapy sessions itself. You know, by the nature of our program, they do 10 or 12 groups a week together, and so there's a lot of overlap, and they get to know each other really well. And unlike traditional outpatient groups, where the only time you know, the patients would see each other was you know, once a week when they get together you know, for the group, our patients see each other all the time, and they form a strong sense of community with each other. We encourage that, and you know, and sometimes they'll organize community outings and do things together, and we'll socialize. Occasionally, there are problems with someone calling a peer, you know, when they're struggling in the evening with urges to self-harm, and it can be really troubling for a peer if they feel that they're being asked to field a situation like that, and we encourage them to, you know, bring a dilemma like that into their treatment, and then you know, the response that we advocate is, you know, if someone tells you about something like that, it's not, you know, it shouldn't be your responsibility, and you want to encourage the person to be in touch with their therapist. Problems of codependency between patients can develop, and I think that too relates to what you're describing, Chris. You know, where they become so important to each other that you know, they take on an importance you know, which takes over, and helping them to establish some separateness so that the relationship doesn't carry so much importance that it interferes with the person getting on with their lives, is often one of the issues that we have to bring into either the individual session or the groups themselves. What happens with most patients in our program, though, is starting with 10 or 12 groups a week plus therapy is a lot. And while our participants will do something like that for the first several months of the program, after the first treatment review, usually we begin a reduction in the frequency of participation, and patients will identify groups that really work for them and others which they find not so helpful. So they'll go down from 10 groups a week to 5 groups a week, and then maybe after 6 months, they'll be down to 1 or 2 groups a week. One of the things we don't want treatment to do is interfere with patients getting on with their lives. Our program has a work requirement where, and we've tried to consolidate the program in the morning as much as possible to leave time in the afternoon for the person to develop non-clinical activities, and we require that they get a 15-hour-a-week part-time job, because all of the research suggests that while patients can get better in treatment and no longer meet criteria for BPD and there can be significant symptom reduction, if they're going to have a happy and fulfilling life, they also need to be encouraged to develop their functional capacities. So our program requires that they get part-time jobs and encourages them to get on with their lives. As they're having more of a life or making plans to return to school, usually there's less room for treatment. And then the reduction from 10 groups a week to 5 groups a week to 1 group a week is what happens. Now, sometimes patients will continue in an interpersonal group or a DBT skills group or a mentalization group, for a year or two, and they find that a useful touchstone, as they go on with their lives. That hasn't led to the kind of problems that you were describing, Chris, about an over-dependency or a fear of abandonment. They get their connection with each other or with their treatment as a kind of touchstone, and it also allows them to get on with their lives and establish relationships in their lives, which can provide that same sense of connection and fulfillment.
So George, that's I think that's a really wonderful model for what everybody's hoping for, and that's kind of the ideal outcome. And one question that's very much related that I think you did address is there a risk of dependence to group therapy? But the bigger question that I want to ask you, because it's come up in almost every webinar, is what do you do when your loved one's just not getting better? When it seems like they won't get a job, or every time they get a job it lasts a week or two, and then there's some interpersonal conflict and they quit, and they seem almost dependent or addicted to being a patient, treatment, group therapy. How do you think about those patients that have been in treatment for 5, 10 years and just don't seem to be able to move on and kind of move on with their life in the way that you described? Are there any recommendations that you have specifically for, because you're speaking to an audience of mostly family members and also some people who have borderline personality disorder themselves. I think there are a handful of clinicians who attend these webinars, but the predominant audience are family members. What would you say to them if they feel like they're in that situation, that their loved one they've gotten years of treatment and for whatever reason they're just not moving on, and they're not getting a job, they're not getting a life, and the only supports they really have are groups or therapy appointments?
Well, that raises 2 possibilities for me. One is that they've been misdiagnosed and they've been in the wrong type of treatment, because patients are supposed to get better, borderline patients in particular. Um, as you know, Chris, BPD used to be almost a pejorative diagnosis that people used when they were fed up with patients or found them impossible. And but the more recent research is that it is one of the most treatable psychiatric conditions around, with a very good prognosis. Even without treatment, patients with BPD will generally get better through the life cycle. Treatment accelerates that process. If we have a patient in our program who hasn't improved after 3 months, we question whether what we're offering is the right type of treatment, because there should be improvement fairly quickly. What we look for as the first thing to change are problem behaviors. The second thing to change, which takes longer, are relationships. And the third thing, which takes the longest, is how the person feels about themselves. But if you don't see behavioral changes fairly quickly, it raises the possibility that it's an ineffective treatment, or what's sometimes called a non-treatment treatment. So with our program, if we don't see someone improving, we'll do a consultation, sometimes with someone outside our program, to take a look at what's happening, because patients should be improving. Now, as I started, I said that sometimes there's the wrong diagnosis. And if borderline patients are in the wrong treatment, it can be iatrogenic. It can make them worse. But if patients are in a borderline treatment and not improving, it may be that the type of treatment that they need is different from what we're doing. And there's been a important development in recent years toward things called life coaching, which has more of a practical emphasis, and it puts much less of an emphasis on talking about one's childhood, or patients can get lost in that. Blaming their parents for what's missing in their lives and things like that. And our experience is that generally that is very unproductive for someone who has been in treatment for a while, and to encourage them instead to get something that really puts more of an emphasis on their functioning. So rather than having an exploratory psychotherapy, we might recommend that they be in something that's more case management based, something that's going to give them some life coaching, give them the skills to be more functional, to have more of a life. So you want to be thinking about this in terms of if treatment's not working, is it the wrong treatment, and offering them something else instead.
Great. No, thank you. I think that's very helpful. Another person asks, is there a benefit, or are there occasions where people with borderline personality disorder should participate in groups with others with a range of diagnoses? So kind of in maybe a general psychiatric group, or a group for people with depression, even though not everybody in the group has borderline personality disorder?
That's an interesting question. And when I started off, the conventional wisdom was you didn't want to have more than 2 borderline patients in a group at the same time, or they would wreak all kinds of havoc. So the fact that our program emphasizes groups that are primarily for people with BPD is different than the way it used to be. I think that's a good question, though, and I do a number of groups. In fact, one mentalization group that has patients from a wide diagnostic spectrum, and that works just fine. There are borderline patients in it. There are people with depression, bipolar disorder. Something that's been really interesting to me is, we talk about Asperger's disorder, as being a problem where the person has trouble understanding somebody else or reading somebody else. And I've been surprised when I've had some Asperger's patients in mentalization group. It is possible to help them to be more skillful about thinking about somebody else and being more skillful in their interactions with somebody else. So I think it's fine to mix it up. In my experience, homogeneity works especially well with groups. You want to have participants who are more or less at the same level of ego functioning, but that ego functioning can lend itself to different diagnostic groups. But it's harder if you have some people who are working and have families and have a career, and people who are on disability and who don't have as much going on with their lives. So being in a group where there are going to be other people who are more like them allows for that commonality of experience that I was describing earlier.
Great. So the next question is another question that has come up in almost every webinar we've done, and the generic question is, what if my loved one doesn't believe they have BPD, or they're refusing to get treatment, so on and so forth? What do I do? And I'll read this person's specific question and scenario. I hear you saying that patients get better even without treatment, but my husband is turning 54, unfortunately not willing to be in therapy, doesn't even believe he has BPD, and in the 5 years of our relationship, I don't see anything getting better. What would you recommend to this type of a person who's really struggling and kind of exasperated? Any helpful hints or recommendations for a loved one of how to approach somebody who doesn't believe they have BPD, doesn't think help is needed? Or
well, answering that question is easy in one respect, and in another respect, it's very difficult. The easy part is I wouldn't make too much of an issue of accepting that they have BPD. It helps if they do, and it's been controversial on the fact in the past. Many clinicians didn't want to tell their patients that they had BPD, for fear that it would be experienced as a pejorative diagnosis or an insult. More recently, people have been open about it, and by and large, patients are relieved to know what they have. They read the diagnostic criteria, and it's comforting to them to say, that's what it is. That describes me, and they feel less alone with it. And to know that there is a specific treatment that's geared to that can help a lot of patients. Not everyone is open to it in that way, just as not everyone with a substance abuse problem is open to accepting that they're alcoholic or something like that. So giving them some latitude to be in something that might accept their ambivalence as okay, and that it's not essential for them to admit they have BPD or admit that they're alcoholic, I think is fine. The person who raised this question, though, is in a tough spot. If you have a loved one who is highly resistant to any form of treatment, and you feel that the relationship is deteriorating, it can really put you in a tough spot. What I would say is to try to be less forceful about it, and to try to express it from a personal standpoint. To say that I want to be close to you, and my experience is that it's been harder for me to be close to you in recent years, and I'd like us to work on this so that we can have our closeness again. Sometimes the willingness of the loved one to become part of the solution can make a difference. But it really goes back to the proverbial you can bring a horse to water dilemma. And there are some people who the harder you push, the more they're going to dig in their heels and the more they're going to resist it. And that can be really tough.
Then the next question is, could you speak a little bit about how treatment programs can address addictions, be they substance abuse, overspending, other types of addictive or maybe reckless behaviors?
Well, the thinking about addictions has changed radically in the 40 years I've been at McLean. When I started out, clinicians took a very judgmental view of people with addictions and were quite confrontative and devaluing of the person. And it was actually, quite chilling to, see the kind of frontal assault on the person's sense of self. In recent years, there's been much more of an emphasis on what's called motivational interviewing. And the task is for the clinician to try to identify things that they and the patient can agree on. Something that they would agree is a problem, and see if they can decide on what the person would be willing to work on, and not try to coerce them into changing or working on something that they don't see as a problem or don't want to change, but to see if there are areas in which the person may have some motivation of their own, and to join them in that. One of the groups that I do for our substance abuse program is called Readiness, and it's based in a concept that was developed by some research in Canada some years back, in which, contrary to what I described earlier about addiction treatment, where you kind of hit the person over the head with their need to be abstinent, and anything other than that was minimization and denial, you would instead try to join the person in having a question about whether it's a problem or not. And people who get referred to the Readiness group are usually referred there because someone else is concerned about their substance use, or it may be that they're aware that it's been a problem for them. There are times when they drink more than they know is good for them, but they don't believe they're alcoholic, and their goal for being in the Readiness group would be to be able to drink in moderation. So my stance as leader is to try to be neutral about whether I believe it's a problem or not, and to try to join them in what they think, and to think together about what really is the effect on their lives of continued using. And according to this Canadian study, when people are given room to wrestle with their ambivalence, the people who decide they do have a problem are much more successful in getting sober and staying sober than people who are railroaded into recovery. In the Readiness group, we will occasionally have people who were referred initially for substance abuse problems, and those resolve, but they identify other addictive behaviors, such as addicted to relationships, addicted to spending, or a lifestyle, and kind of consistent with the model of joining the person where they are. I'm open to shifting the focus away from substance use issues to identifying another problem behavior, and to see if I and the rest of the group can join the person in identifying what's the effect on their lives, and by giving them the room to wrestle with their ambivalence about it. More often than not, people identify ways in which they want to change, and the motivation comes from themselves.
Another question relates to the question of comorbidity. So I just want to make a note that several people have asked about comorbid conditions. So can borderline personality disorder exist with OCD? what are all the comorbid conditions and other questions like that. And I'm afraid that we may not have time to get to all of those questions, but I want to refer all of those people to one of our last webinar, actually. So if you go to that first web link, you'll come to the BPD Patient and Family Education Initiative website. And Dr. Amy Gallardi gave an entire presentation on comorbid diagnoses with borderline personality disorder. So if we don't end up having time to get to your questions, I want to make sure that if you didn't participate in that webinar, that you know that that exists. It's available now. You can watch it. But one specific question kind of related to comorbidity, and you referred a little bit to misdiagnosis. And so one person asks, you know, how common is it that someone who initially exhibits symptoms of borderline personality disorder, they get treatment, those symptoms seem to resolve, and then they begin to exhibit different symptoms, maybe associated with a different personality disorder, such as histrionic, narcissistic, or maybe just a different disorder altogether. Do you see that? And if so, how do you think about that?
Well, comorbidity happens a lot, and 20 years ago, even though I was working in the borderline program, I started doing some work in our substance abuse program, and I was impressed that about 70% of the people in the substance abuse program seem to have problems with personality disorders. And as I learned more about substance abuse disorders, I began to recognize how many of the borderline patients had problems with substances. And it turns out that the overlap is about 2/3. So that is huge. And we do have new treatments that address this dual diagnosis. And Marshall Linehan has developed a form of DBT which addresses that. And the substance abuse program here has developed a whole protocol for treating BPD and substance use disorders. Eating disorders are also something that happen in our program all the time. And until recently, we have had less of an emphasis on that. We now have a group called Food and Mood, which allows people to address their problems with emotional eating or binge eating and or over restricting and things like that. But I regret that it's an area of treatment for BPD and comorbidity, which we haven't done a good enough job of in the past. We're getting better at that, and I think we can get better still.
Great. So the next question is a little bit different than what we've been talking about. This person asks, have you observed any people with borderline personality disorder that seem to limit the attention-seeking kind of traits to intimate relationships, but with almost all other relationships being extremely cautious and reserved? Almost shy. And I guess the broader question is, do you sometimes see a difference in the way symptoms of borderline personality disorder are expressed with parents or with siblings or with friends or with an intimate partner? Are there situations where sometimes one person, say the intimate partner, is saying, oh my God, this is a nightmare, and the other people are all looking at him or her like, what are you talking about? She's so wonderful, and there's no problem.
Well, I think parents tend to get the worst of it, and it happens a lot that a person can be fine with everyone else and hell on wheels, when they're at home, and that's a challenge. I wasn't sure I understood the first part of the question. Was it alluding to problems with promiscuity?
I don't have specifics. So I have attention-seeking in intimate relationships.
Well, that is one way to get attention, being promiscuous. But in my mind, that's more of an out-of-control behavior, similar to binge eating or substance abuse. I mean, there's nothing intimate about promiscuity. most people with BPD have a deeper yearning for a very close connection, with someone else. As I tried to convey in my introduction, sometimes they need it so much they can't stand it, and so that while they seek it and desperately crave it, whenever anyone gets close to them, they feel suffocated by it, and they can be quite rejecting from the person who's trying to be close to them. One of the characteristics of BPD is while there might be an ideal spot in the very middle, if you err on by 1 millimeter on one side of that, you're either neglectful and abandoning, or if you're 1 millimeter on the other side, you're suffocating and controlling. So it can be really challenging to address this issue, and it's especially hard for the people that the individual is closest to, like family and romantic partners. A lot of times the person is defended against the fact that they actually have these deeper yearnings, and part of the task of treatment is to help them recognize that that is there, and to be able to approach it in their lives in ways which are less likely to drive others away or backfire.